you for generous introduction, Hina. Honorable chairs, foreign and local faculty, delegates, and my students. I was asked to talk on the management of H. pylori, and you know, management is not just a treatment. First, you have to understand the disease, and you have to diagnose the disease, and then you can treat. So I've added these components also. So I'm presenting on behalf of Abbott Laboratories, but there's no financial implication, and I don't think I'm going to receive honorarium also. The contents are entirely my own. The Helicobacter pylori, this is the picture, is one of the most robust organisms. It was discovered in 1983 by Warren and Marshall in Australia. They won Nobel Prize for this. Acquired through oral or feco-oral route. Oral, like kissing, or even non-sexual kissing, or food contamination. Sharing foods could transfer the infection. And fecal-oral, like poor personal hygiene, somebody handling food, and that can transfer the infection to the other one. This organism lives mostly in the mucous layer of the stomach. It could go deeper. It could cause bacteremia also, and in some cases it may cause at least some antigenemia. It has got double cell membrane, and that makes it very, very tough organism to eradicate. And it is also equipped with some specific enzymatic system which is responsible for the pathogenesis and the disease caused by it. And it has been identified as group 1 carcinogen. That means we are very sure that this can cause cancer in the stomach. So the first question is H. pylori a friend or foe? It may be a foe because it causes gastritis. It can cause gastric and duodenal ulcer and further complication like bleeding and rupture. And it may cause malignancies. But it may also be called a friend because it had lived with us for millions of years, just like a commensals. There are so many people who are infected, at least as per antibodies are concerned. They are infected or they were infected, but they don't have any symptom. And there is evidence that H. pylori may actually protect you against certain allergies, asthma, celiac disease, and some infection. So what turns this friend into foe, we don't really understand. At least I don't. Something happens that this H. pylori, which was present in the stomach, sleeping, hibernating, suddenly becomes active and decides to cause a disease. So in pathogenesis, first of all, I think this germ has got the ability to survive in a highly acidic environment. In stomach, the pH could be as low as 2. And most organisms, they cannot survive in this acidic environment. In fact, our gastric acid is like one of our immune mechanisms. But this organism has got a special mechanism. It has got the ability to split urea into ammonia, ammonia being an alkali, and this bacterium moves with a cloud of ammonia, alkalinity, and it can survive in the mucous layer. And it also stimulates gastrin-producing cells and cause increased HCl production. It can also inhibit somatostatin producing cells that they are protective, so both of them may be actually responsible for causation of peptic ulcer, both duodenal as well as gastric. And it also enhances cellular growth and may cause metaplasia, and that can be responsible for cancer, both the mucosal cancer and also the lymphoid tissue in the stomach that can also turn into cancer. Then it actually produces many cytokines, and these cytokines are absorbed, and they may cause many other symptoms, like may cause malabsorption-like syndrome, and they may also cause many systemic symptoms, many unexplained chronic symptoms like chronic fatigue syndrome, myalgias, they can also be attributed to H. pylori infection. Importance may cause chronic atrophic gastritis, and due to atrophic gastritis, it may impair absorption of many nutrients like vitamin B12, vitamin D, and folic acid, and iron, may cause gastric ulcer, duodenal ulcer, and may be responsible for non-healing or recurrent ulcer. Now, it has been observed, if there's somebody who has H. pylori-induced peptic ulcer, and if you give him a good dose of PPI, most probably the ulcer will heal. But the chances of recurrence are very high unless you eradicate this organism. Malignancies, adenocarcinoma, maltoma, and esophageal cancer, they of course are very, very good reason to treat this organism. Many extrahepatic manifestations like ITP, in some people with ITP, this organism may be a triggering point, iron deficiency anemia, ischemic heart disease. There could be what is called coronitis. The coronary arteries, they get inflamed and they can cause ischemic heart disease and many other conditions, and one of them is chronic fatigue syndrome. So people who we treat them as fibromyalgia or depression, some of them may be actually suffering from H. pylori infection. Now, these are the symptoms of GIT, and you can see nausea, vomiting, abdominal pain, heartburn, diarrhea, halitosis, plus many systemic symptoms. Now, diagnosis, I think these are 5 tests which can be used. If you have 5 tests or 5 treatment options for one disease, that means none of them is 100% satisfactory. Now, I'm going to talk about them one by one. First of all, antibody test. It's an easy test. It is used for screening. So a positive test would mean that this person is suffering from or had suffered from H. pylori infection. It does not indicate a current infection. And it is not useful to check the efficacy of the medication also. So diagnostic value, if only positive, if somebody was known to be negative only recently, and now the test has become positive with symptom, I think then this test can be considered diagnostic. Stool for H. pylori antigen, it is little cumbersome because I've realized that people do not feel very comfortable collecting their sample of stool and giving it to the laboratory. But it confirms current infection or at least colonization. A positive stool antigen would mean at least the presence of H. pylori in the stomach. It is very, very specific, 98%, and very sensitive, 94%. So quite useful test, fairly expensive, I think 5,000 rupees in Pakistan. It is used to confirm the diagnosis and also to confirm eradication. Widely available, most laboratories are doing, and now the home kit is also available. So the principle of urea breath test, I love to talk about this. This is a very interesting test and very convenient. I think in the West, this is probably the first screening test and the diagnostic test. So somebody where you suspect H. pylori infection, you would give him this drink. It has got urea, that is carbon 13. Normal carbon is 12. Carbon 30 so that we can chase this. In a normal healthy person, this will just pass through the stomach in the stool. But if you have some organism in the stomach which is producing urease, that would split this urea into ammonia and carbon dioxide. And this carbon dioxide can be detected because it has got carbon 13. And the only organism, there will be an assumption that there is something which is producing urease in our stomach, because our normal stomach cells, they do not produce urease. So if there is the presence of urease would imply some organism which is producing urease, and there are many organisms which can produce urease, but the only one which can survive in that highly acidic environment is H. pylori. So we assume that there is a H. pylori. This would be exhaled into the air and can be detected. So this is how it is detected. I will not go into the details because of the time is a problem. So this is the technique. Patient uses this kit, collect the sample, 3 or 4 samples before taking the drink, and then after that, and that is sent to the laboratory. So the diagnostic value interpretation confirms current colonization and infection, very specific 98% and sensitive 94%, used to confirm eradication, and home test kit is also available. So endoscopy, I think, is a very definitive test, but many people, they hate to undergo endoscopy. It is most definitive test. It is definitely indicated where you suspect that there could be something else. As a good clinician, in all clinical situations, you should always ask yourself what else it could be. So especially in elderly people, especially those who are not responding to treatment, you must suspect some other condition. So I think endoscopy should be done. So with endoscopy, you could have normal appearance. You could have appearance of chronic gastritis, atrophic gastritis, intestinal metaplasia, dysplasia, gastric adenocarcinoma, or maltoma. So all these are possible on endoscopy. So once you get the sample, you of course take the biopsy. You first see the picture. This is the picture of gastritis. I see some gastroenterologists here. Please excuse my ignorance. The picture does not truly represent gastritis. So, and one simple way of testing for urease is this rapid urease test done on the biopsy specimen. And the principle is that the tube on the left has got some reagent, which is yellow in color. And if you change the pH to alkali, it would turn pink. So the biopsy specimen is put in here. And if there is H. pylori, that will make urease, and that will produce ammonia, and that will turn the reagent pink. So next time you see it is pink, so you would assume that this is H. pylori positive. Or the biopsy could be seen under microscopy. H. pylori can be identified with H&E staining or Giemsa staining. Culture and sensitivity is usually very difficult because this organism is very, very demanding. It is not easy to grow, although the scientists have developed the technique, but it's not routinely done. It's not easily culturable. A molecular test, the PCR, is very, very promising because it has got 100% sensitivity and 100% specificity. What else do you want? One test which will tell you surely if H. pylori infection is there or is not there. Plus, it can also tell you the resistance to clarithromycin, which is the primary treatment. So I think it's a great test. PCR, I think, should be the standard test for a diagnosis of H. pylori infection. So this is the picture histology, and these H. pylori, they can penetrate into the crypts. I think the question is, treatment, you have made the diagnosis, should we treat or shouldn't we treat it? I earlier said it could be for or friend. So pros and cons of treatments are discussed, and I think the physician will make his own judgment. It will remain an individual decision of the physician whether to treat or not to treat the individual. So pros in favor of treatment, recurrence rate very low. If you don't treat, eradicate H. pylori, peptic ulcer would come in about 90% of the case in 1 year. And if you eradicate it, the chances of recurrence of ulcer is less than 10%. Prevention of cancer, very, very good reward. And psychological relief. Somebody who is suffering from some infection knows that his infection is over, would get a lot of psychological relief. And then risk of transmission to others would also be minimized. So all these points favor the treatment. Now let's see the other side of the picture. Many positive cases are asymptomatic, especially positive only on antibody. They're asymptomatic. It is very difficult to convince somebody to get a difficult to tolerate treatment who is asymptomatic. No 100% effective treatment is available, and all treatment available are characterized by the unpleasant side effect, and recurrence from the same source is very high. If the source is contaminated community water, that person, after a very difficult eradication, is going to go back to the same community and going to drink the same water and going to get the same infection. So I don't see there is points unless you can improve overall hygiene condition of that person, the family. So you will decide whether or not to treat. Several regimens are available. None is 100% effective. None is clearly better than others. All have unpleasant side effects. And PPIs or PCABs are always included because antibiotics do not work in very acidic environment. Now compare it with chronic hepatitis C infection. For chronic hepatitis C, we just have one pill which works in almost all individuals, almost close to 100% response rate, and the tolerability comparable to placebo. Now, compared to this, here nothing is ideal. So it's a very, very difficult, actually, challenging task to treat these patients. So there are 3 lines of treatment: first line treatment, second line treatment, third line treatment. The best is first line. The most effective is first line. Don't think that the second line or the third line is more effective. Just like in TB, the first line is the most effective treatment. Second and third are the only left choices if first line does not work. So the first line treatment consists of many regimens actually: clarithromycin-based triple therapy and clarithromycin-based sequential quadruple therapy. There are other ones: non-bismuth quadruple therapy, bismuth-based therapy, levofloxacin-containing therapies, concomitant bismuth-based therapies, but I'm going to talk about in some more detail for the first 2. So you give proton pump inhibitor, anyone, like omeprazole or any other one, rabiprazole, usually double the recommended dose. If you use omeprazole, you will give 20 milligram twice a day, and you give it for 2 weeks. Along with that, you give antibiotics, clarithromycin, 500 milligram twice a day for 2 weeks. Literature says could be 10 to 15 days. I always give them for 15 days because I know, and the literature supports my idea, that the longer duration improves the chances of eradication. And amoxicillin 1 gram twice a day. So both of them to be taken in this dosage for 2 weeks along with double dose of omeprazole or the PCABs. PCABs are not only a good substitute of PPI, but can be actually more effective. There's one study which shows that it is better than PPIs. And after 2 weeks therapy, patient must continue the PPI for at least 2 weeks. And with this regimen, the efficacy is around 80%. If patient takes the medication, the weight is recommended, 80% max. And the other regimen is clarithromycin-based quadruple sequential. Now, this is actually, again, first part is the same, PPI or PCAS, double dose for first 10 days. And first phase is to give amoxicillin, 1 gram BD. Since patient is taking just one antibiotic at this time, maybe patient can tolerate it better. And the theory behind this is that this organism has got double cell wall. By giving amoxicillin, we make the cell wall defective. That means the antibiotic in the second phase will penetrate the germ better and they will produce better results. So the first 5 days, amoxicillin 1 gram twice a day. It should be followed by 2 antibiotics, clarithromycin 500 milligram twice a day for 5 days, and tinidazole 500 milligram twice a day for 5 days. So total is 10 days. These 2 drugs, they may cause side effects. Amoxicillin would cause GI upset, but otherwise it's okay. But clarithromycin and tinidazole is going to, I think, cause definitely bitter taste in the mouth because both of them are notorious for this. This again will be followed by treatment with just omeprazole for 2 more weeks. And the efficacy of this sequential quadruple therapy, clarithromycin based, is 90%. So this sounds little better than the first regimen. Both are considered the first line treatment. Now, along with this antibiotics, you also give some supportive treatment. There is some evidence that the multi-strain probiotics may be helpful because H. pylori can also cause dysbiosis. So multi-grain probiotics may be helpful, and broad spectrum vitamins, minerals, and trace elements should also be given because you don't know which element is deficient because of the gastritis. Patient may be suffering from some these micronutrient deficiency which may be responsible for some of the symptoms. Antidiarrheal, simethicone, and antacid. When I was preparing this presentation, I went through this some natural, so this L is missing, some natural remedies. Mastic gum is something which comes from Mediterranean tree, and I don't really know what this thing is, but this as a therapy has got about 60% eradication rate. Then black cumin, kalwanji, curcum, haldi, curcumin, haldi, ginger, licorice. They're not only great in taste and flavor and spice, but they also cure your H. pylori. Then some foods, some anti-inflammatory foods like broccoli, honey, red wine, cranberry, and green tea. They're all supposed to have some beneficial effect in H. pylori. Of course, I would always give them as a supplement to antibody because they are more scientifically validated treatments. Now, overall treatment plan and retesting, first of all, you establish the diagnosis. You discuss the treatment plan with the patient because we all agree that patient has to be in the center of decision making. Patient has to be an active partner. You discuss the cost, you discuss the expected side effect, you discuss the reward and all the things, and then you decide whether or not to start the treatment. And then execute treatment consisting of 2 antibody regimen I just mentioned. And then 2 weeks after the antibody course is completed, 2 weeks just PPI or PCABs. Another 2 weeks, patient should be off PPI and PCABs, and then you retest. And you don't retest with antibodies. You don't retest with the gastroscopy also because patient would not like that. So you test with a non-invasive test. I think this breath test, urea breath test, or stool H. pylori antigen, both are great. Be prepared to expect that this test may still be positive because all do not respond. So a patient has got symptomatic improvement and test is still positive, I think I would give him some more time and retest after 4 weeks. Patient should be off antacid and ranitidine also for 24 hours before you do this test. And patient should be fasting for at least 12 hours to get the test right. So whether screening and treating asymptomatic individual, does that make any sense? I think there are trials that if there are people who have some vague symptoms and you may screen them for possible H. pylori infection, and studies have shown and it may be a cost-effective approach. So to sum up, H. pylori infection is extremely common. The prevalence is according to one's age. Average 50%. If I'm 68 years old, I have 68% chances that I may be suffering or had suffered from H. pylori infection. So extremely common. Eradication should be considered in symptomatic patients and confirmed cases because treatment is hard and treatment is not effective in 100% of the cases. So it's only symptomatic people and confirmed cases. Gastric martinoma, however, is a definite indication for H. pylori eradication because it improves the outcome. Clarithromycin-based first-line therapy should be the first choice. Again, I say it does not work in 100% cases, but it is better than other. We have hybrid regimen, we have other regimens. I think it is still better than others. So that should be based, either you use clarithromycin-based triple therapy or clarithromycin-based quadruple sequential therapy. This should be tried first of all. Screening of people with vague GE symptoms, systemic symptoms is warranted. And asymptomatic, this is my own approach, you may disagree. Asymptomatic people without definite evidence of H. pylori are best left alone. So I hope I was able to make a simple version of this complex topic, and because my colleagues know the simplicity is in my genes. This lecture, thank you. This lecture is also available on my channel, Medurstand. This and many, many more lectures, and I think the contents are more about than what we talked about here. I think my time is up and I'm done. Thank you.
Thank you so much, sir, for an edifying talk about the management of H. pylori. With this, we are done with